A patient walks into the clinic complaining of a painful red eye. We see a localized sectorial injection of the blood vessels. The redness is concentrated in a distinct wedge rather than covering the entire globe. This specific presentation triggers a broad differential diagnosis. We must determine if this is a benign surface irritation or a severe, vision-threatening intraocular condition. The immediate clinical challenge is isolating exactly which anatomical layer is inflamed. Is it the superficial episclera or the deep structural sclera beneath it? Relying purely on how the eye looks is dangerous. The visual presentation of these layers overlaps heavily. We need a rigorous, step-by-step examination algorithm to systematically rule out the threats in the correct order. Our initial differential diagnosis contains a dozen possibilities, from simple conjunctivitis to acute angle closure glaucoma. Surface-level issues like dry eye rarely threaten vision. But deeper conditions like uveitis and true scleritis can cause permanent structural damage if missed. To prune this list, we start with the absolute baseline, measuring visual acuity. A drop in vision immediately signals a deeper, severe pathology. Next, we check intraocular pressure. This specifically rules out acute angle closure glaucoma, removing an immediate emergency. Then we move to the slit-lamp. Here, we check for corneal staining to rule out keratitis and examine the anterior chamber for inflammatory cells to rule out uveitis. Once visual acuity, pressure, and the slit-lamp rule out refractive errors and anterior chamber emergencies, our diagnostic focus narrows. The problem lies specifically within the vascular layers, meaning we must differentiate the episclera from the sclera. To confidently separate these two layers, we use a definitive pharmacological tool, the phenylephrine 2.5% drop test. Phenylephrine is an alpha agonist. It acts selectively as a vasoconstrictor on the superficial episcleral vessels without affecting the deeper scleral vessels. When we apply the drop to a purely superficial inflammation, the episcleral vessels instantly constrict. The tissue blanches, shrinking back and turning white. If the redness completely disappears after the drop, we have our answer. The diagnosis is confirmed as simple episcleritis. However, if the deep vessels remain stubbornly dilated and the eye stays red despite the phenylephrine, the inflammation is seated deeper. The diagnosis is scleritis. Successfully isolating the inflammation to the superficial episclera allows us to drastically de-escalate the treatment protocol, sparing the patient from unnecessary heavy-duty steroids. For simple sectorial episcleritis, the baseline management plan is straightforward: patient reassurance. The condition will resolve by itself. We prescribe palliative care consisting of ocular lubricants 4 times a day and warm compresses to safely overwhelm the local pain receptors. If the pain is intense, we can safely escalate to weak topical steroids like fluorometholone 0.5% or use topical NSAIDs. But there is a major clinical trap here. Patients frequently self-medicate with over-the-counter redness relief drops to improve the eye's appearance. These drops commonly contain naphthalene, a potent alpha agonist. While they temporarily whiten the eye, chronic use creates a physiological debt. As vasoconstrictor molecules bombard the tissue, cells adapt. They downregulate their alpha receptors, removing them from the cell surface. When the patient stops the drops, the remaining receptors fail to maintain normal tone. Vessels expand massively, causing severe secondary redness, rebound episcleritis. Treating an inflammatory condition purely symptomatically with vasoconstrictors actively worsens the underlying cellular pathology and delays actual healing. But what if the phenylephrine test revealed deeper inflammation? If we are dealing with nodular episcleritis or true scleritis, our approach completely changes. We immediately escalate to strong topical steroids, prescribing agents like Pred Forte 1% or Maxidex 4 times a day to suppress the immune response. And if the inflammation breaches the anterior chamber, we enter the most severe state in this algorithm, uveitis or sclerokeratouveitis. Managing uveitis requires a mandatory addition to the pharmacological regimen. We must introduce cycloplegic drops, like atropine or tropicamide. These drops serve 2 critical functions. First, they paralyze the ciliary muscle, relieving the intense, throbbing pain caused by ciliary spasm. Second, and most importantly, they save the patient's vision. By dilating the pupil, cycloplegics physically pull the inflamed iris away from the lens, preventing sticky scar tissue, known as posterior synechia, from permanently fusing the two structures together. For deep, recalcitrant scleritis that ignores topical treatments, we must abandon drops entirely. We escalate to systemic immune suppression, such as 60 milligrams of oral prednisone. Passing the anatomical threshold from the episclera into the deep sclera or uvea demands a complete shift in strategy. We move from local symptomatic relief to aggressive immune suppression. This points to a core clinical rule in ophthalmology. Deep ocular inflammation is rarely an isolated event. It is frequently the first visible, localized symptom of a widespread systemic disease. We categorize the potential systemic triggers, starting with the most statistically likely culprits, systemic autoimmune conditions. The inflammation in the sclera often mirrors joint inflammation. A patient with severe scleritis is highly likely to be suffering from rheumatoid arthritis. Similarly, the immune complexes attacking the eye can point directly to systemic lupus or granulomatous diseases like sarcoidosis affecting the lungs. If we rule out autoimmune conditions, we must investigate infectious causes. Viral threats like herpes zoster and herpes simplex are common instigators. We also have to screen for insidious bacterial infections, specifically tuberculosis and syphilis. Look at this historical chart from an early venereal disease center. The link between ocular pathology and systemic infections like syphilis carries deep clinical weight and remains a mandatory part of modern medical workups. Because the eye is uniquely transparent and highly vascular, it acts as an exposed diagnostic window, allowing us to observe the effects of hidden, life-threatening systemic pathologies. Beyond autoimmune and infectious causes, a complete workup requires reviewing the patient's pharmacological history, looking for drugs like bisphosphonates or mitomycin, and checking for prior ocular surgeries. We have to be thorough because the physical prognosis of unmanaged scleritis is extreme scleral thinning. In the late stages, you may see a sclera with no active inflammation. This is a highly dangerous sign. The tissue is so thin that the structural integrity is gone, creating a high risk of ocular perforation. This dictates our mandatory clinical directive. When a patient presents with true scleritis, we immediately refer them to a rheumatologist for comprehensive medical workups and systemic immunosuppressive management. Effectively diagnosing a red eye secures the patient's vision and serves as the critical first line of defense against life-altering systemic disease.